together with you, but we'll make up for it today because this is a 2-hour session that I think you're going to enjoy. A little bit further on in the session, I'll give you a little bit of a background to the actual topic. But we're going to start off with a couple of questions in a row, and I'll answer those first, and then we'll get from there. Now, a couple of points just to mention. You will be able to get access to 2 free books that I've provided by simply clicking on my bio. When you get to the bio, you'll see the links for the books that I've written. One of them is on the topic of recurrent pregnancy loss, and this information is not readily available everywhere, so I urge you to go there and get that book. Then there's another thick book, which is over 300 pages long, which I wrote recently. Both of these books come to you free of charge. No commitment requested or required. Simply will be automatically sent to you when you click on the bio and go to those points. There's another link on the bio which allows you, if you're interested and feel the need to talk to me, all you got to do is click on that link and automatically a 4-minute rapid questionnaire will appear that you fill in, and that'll just automatically end up with us. When we get that, if we get that from you, we'll then reach out to you. But again, there's absolutely no commitment. Ultimately, this particular webinar, along with all the others I do, will appear on YouTube, and you're able to go looking there at Jeffrey Sher MD. And you'll find me there, and you'll be able to look at all the videos. We'll remind you of this as we go along. So to get started with, we'll take a few questions as they come. And helping me today again is Josh. Josh has been phenomenal. He's helped me all along with these webinars, and he's a real expert. He'll be taking your questions, relaying them to me, and I'll answer them as they come. Now, while the topic of discussion will be pregnancy loss, miscarriages repeatedly, you can ask me any question on any topic in the field. I'll do my very best to answer them for you. So let's go.
We actually don't have too many questions in just yet. We've got some people rolling in right now. So I'm going to read off a few questions over on our post here. Let's go down real quick here. All right. Tatsa says, where are you based? Where is your location, and how do you serve people?
I am located in Las Vegas, and I go intermittently to New York. Our headquarters is in New York. It is Sher Fertility Solutions on 38th and 5th Street in Manhattan. The medical director there is Dr. Drew Tortoriello, and with him is Dr. Sitara Ravikumar, both outstanding fertility doctors. I've been working in partnership with Dr. Tortoriello for nigh on 2 decades, and of course, when you work that long with the same person doing things identically, you soon become like 2 peas in a pod, and we are. And it's extremely important in the IVF arena that you have access to more than one doctor, because no one doctor can meet all of the needs of all of the patients. So we are in New York, and you can reach us by going to our website. And the website is going to be found at Sher Fertility Solutions, and you can look it up on Google.
Perfect. We're going to answer a few questions now that they're rolling in here. Isabel Moore on TikTok says, I had 2 miscarriages and each time had subchronic hematoma and no heartbeat at 6 to 7 weeks. What could that be?
We're going to get into this in a little bit more detail, but let me explain that most miscarriages, once the pregnancy is visible by ultrasound, which by definition is then a clinical pregnancy, and that happens around 6 weeks of pregnancy, we can see the actual developing conceptus inside the sac. Most of those losses start with bleeding behind the root system of the embryo attaching to the uterus. Whether that blood becomes visible behind that root system that will ultimately become the placenta or not depends upon where the bleeding is, or whether it can track out and escape through the vagina as vaginal bleeding. In some cases, it collects in a pool first behind the root system of the embryo, and then it's called a subchorionic hematoma, and you can see it. Not all of these mean you're going to lose the pregnancy. There are many, many cases where subchorionic hematomas develop, and then they dissipate and disappear over the next number of weeks. So it doesn't mean it's gloom and doom, but if there's bleeding and they see a subchorionic hematoma, it really doesn't make it different from any other miscarriage, because most miscarriages start off with that degree of bleeding, which then separates the root system, or what will be the placenta, and depending on how much of it is disrupted through the separation process, the pregnancy remains viable or it doesn't.
All right, I want to respond to Lo. What are common causes of recurrent pregnancy loss? How can you advocate to be put on progesterone?
Well, I'm going to talk about this as soon as Josh indicates to me that we've got a lot of people over here on the wanting to start.
We've got about 115 right now.
115.
Yes, sir.
Do you think I should start now, or should I wait a little bit longer?
I'd say let's answer like 2 more questions and then let's go into
Well, let's leave this to be answered in that dissertation I'm going to give in a few minutes.
Sounds good. Lo, we will answer your question shortly here in depth. I'm going to answer real quick just another question.
For those of you that are there now, I made an announcement earlier on. I'm not going to repeat the whole announcement, but it's so important for you to click on my bio and get access to the 2 books that come free automatically by return email to you at no cost. And so you should, because one of those books is called The Immunologic Basis for Recurrent Pregnancy Loss, and you're not going to get much of that information elsewhere. So I urge you to get the book. It's only 50 pages long, and you'll be able to read it. And then there's additional information. In the thick book, you also get free in that same request as a download. And I provide to every one of you that want it, and you should. I urge all of you to do that because there's no downside. There is no solicitation. It's simply to get you the information. My job is only twofold: to inspire and educate. And that's all I'm going to be doing. So you can get these books. There's not a single reason why every one of you shouldn't go and click on the bio, get the books, and get an article that I've just completed and just written on recurrent pregnancy loss. I think you'll find it refreshing, informative, and helpful. So get that article and ask for it as well.
Perfect. Just like Dr. Scher said, he's answering questions today on RPL, recurrent pregnancy loss. If you have a question about that, please go ahead and leave it in the chat. He's going to go into a brief seminar here and just share briefly about RPL and some solutions and his experience with it. So we'll answer questions in a second here. We've got about 130 people here, if you'd like to start.
Should I start now?
Yeah, I think now's a good time.
Okay, and for those that miss it, they can get this again from YouTube later on.
Yes, sir.
And we post it within 48 hours or so.
We are at Dr. Jeffrey Scher on all platforms. You can look us up on YouTube and rewatch any of our previous lives where he answers in depth about other topics.
Okay, let's look at having a baby as planting a seed in your backyard. In order, if you want a healthy plant to grow, you've got to plant a healthy seed, and you've got to plant it in a soil that is receptive to the seed. You can't put a good seed in a bad soil or a bad seed in a good soil. It's got to be a good seed planted in a good soil. The seed is the embryo, and when it divides and develops for 5 or 6 days, it becomes the advanced embryo or blastocyst. And that's the stage at which it implants. Starts implanting about 7 days after you ovulate, or 7 days after you get a trigger shot of HCG, or 7 days after you start taking progesterone to create a basis for implantation in a frozen embryo transfer cycle. So you've got to have a good seed. What is a good seed? There are many factors: genetic, metabolic factors, but the most important one by far is the chromosomal integrity of that embryo. Embryo has to have 46 chromosomes, which is what we call the normal human genome. If there's even one more than 46 or one less than 46, the embryo is incompetent or aneuploid. And an aneuploid embryo, unless some of the other cells are normal, in which case we call it as being a mosaic, but in most cases, if it starts with the egg, and it usually does, being chromosomally abnormal, the embryo will then always be chromosomally abnormal, incompetent or aneuploid, and will either not even continue to divide, or it will divide but it won't attach to the uterus and you won't even know you were pregnant, or it will attach briefly and be lost before you can see the pregnancy by ultrasound, in which case we call it a biochemical or chemical pregnancy, or it will go on later and then you will lose it as a miscarriage. Now, most pregnancy losses, 80%, are sporadic. They occur because there's something wrong with the embryo. Something was wrong with the seed. And in that regard, those pregnancies usually are lost so early that you don't even know you're pregnant, or you have an early biochemical pregnancy loss, or very early miscarriage. In about 20% of cases, you lose a pregnancy in a miscarriage not because the seed was abnormal, but the soil or the uterine lining is not fully receptive. We call that implantation dysfunction. Again, here there are many factors that can play a role, but the most important factors are 3 in number. 1, it is a thin uterine lining, so there's nowhere for the roots of the embryo to take proper hold because the uterine lining is too thin. I was the first to show this back in the 90s, published on it and written books on it. So if there's a thin uterine lining of under 8 millimeters, the pregnancy's, the embryo's root system will not attach properly and will come free and you lose it. Either before you even know you're pregnant, you'll think you're infertile, but you're having a mini miscarriage so early you never knew you were pregnant in the first place. Or it'll limp along and then run out of steam. And even if that's a normal chromosomal embryo, it's not going to take hold and you won't be successful in many cases. A thin uterine lining, in my book, because I'm the person that first described it in the 90s, is one that's under 8 millimeters. On the day you ovulate normally, or on the day you take an HCG trigger shot, or on the day you get progesterone given to you for a frozen transfer. So we have to have a lining at that point, not when you put the embryo in the uterus, not a few days after ovulation, but at that point it needs to be at least 8 millimeters thick. Ideally, it needs to be over 9 millimeters. 8 to 9 is a gray zone. Under 8 is a bad case scenario. I don't prefer to transfer embryos into anyone's uterus if the lining is less than 8 millimeters. Because even if you get pregnant, and even if it survives, that pregnancy is not going to thrive in the uterus. And then you're dealing with a baby that doesn't develop properly, prematurely delivered, doesn't grow properly and is growth retarded, and may have neurological and physical ailments for the rest of its life. So I don't believe that that's a wise thing to do. Today, through methods we developed in the 90s, we can use something called vaginal Viagra suppositories, which is a compounded form of the regular Viagra that some men need. And it's then inserted into the vagina 4 times a day in the cycle in which we actually put the embryo in, be it fresh or frozen. And then what that'll do, as with a man, it'll open up the blood vessels in the uterine lining, delivering more estrogen to the lining so that the lining can develop properly. So the combination of estrogen and Viagra in such cases will in most cases reverse a thin lining, not in all cases. If that lining has been so destroyed that there's nothing to grow, it's not going to happen. But in most cases, we can open up the blood vessels and improve the lining. The second cause of an implantation problem is where the uterus inside is not smooth and regular. It can't have little outgrowths, scar tissue, little polyps that are like little mushrooms growing into the uterine cavity, or fibroid tumors in the wall of the uterus that protrude into the uterine cavity. Those things irritate the lining and reject the embryo. They work exactly the same way the contraceptive device known as the IUD works. The IUD is put in the uterus not to prevent a woman getting pregnant, but to irritate the lining so the pregnancy that reaches the uterus after fertilization won't attach. And you can have your own foreign body if you've got scarring, fibroids or polyps growing into the uterus. And these have to be checked for. We check for them by doing two things, primarily. One, a simple saline ultrasound, known as an HSN or SIS. We inject water into the uterus, distends the cavity, we do an ultrasound, we can map out the contour of the uterine cavity and deal with it. In my practice, we deal with this by doing the saline ultrasound in the woman free of charge at the egg retrieval. And if we find there's an abnormality, the woman will have gone into the egg retrieval, giving us permission to clear it and fix it. So when she wakes up, the problem is gone. And by the way, when she's asleep, having the egg retrieval, we also measure the thickness of her uterine lining to see if that's a problem that may have to be fixed in a subsequent cycle where we do a frozen transfer by using estrogen and Viagra. The third factor is an extremely important one. The one that you'll find in that thin book I'm giving to you free by simply having you click on the link in my bio. And it's on recurrent miscarriages due to immune causes. Now this is a controversial area. Most people, most physicians I'm afraid, don't fully understand about it. It's more complex than the entire field of IVF. So most doctors shy away from it and you get the kind of answer, oh, I don't believe it. I don't believe that's a factor. Well, I'm telling you, after 40 years in the field and having been influential in the births of over 17,000 babies, it is a factor. It's a very important factor. Thousands and thousands of women come to us from all over the world to gain access to her. Our expertise in the area we help develop, which is the area of clinical immunology or reproductive clinical immunology. That is where the uterine lining is immunologically hostile to the embryo. So it won't attach. And the reason that happens, usually, with implantation problems that are immunological, is one of two reasons. Either there's an autoimmune underpinning. This happens in women with endometriosis, which many, including myself, believe has an autoimmune component. Or things like where you have a family history of autoimmune diseases like lupus erythematosus, rheumatoid arthritis, or hypothyroidism, or scleroderma, or celiac disease, or we can go on and on. When you have got these autoimmune conditions, you have a predilection to have cells in the uterine lining that journey from your bone marrow to get there every month, called natural killer cells, and they comprise 60 to 70% of all the immune cells in your uterus. These natural killer cells, along with other immune cells known as activated T cells, release toxins called cytokines. And they're not all toxins, they are growth factors that are also cytokines. There are two types of cytokines, type 1 and type 2. Type 2 attracts the roots of the embryo into the wall of the uterus. The type 1 cytokine trims down the roots of the embryo like you prune a tree. And the whole purpose is to avoid the roots growing right through the wall of the uterus into the surrounding pelvic tissue and causing a disaster. There's got to be a balance between type 1 or TH1 and type 2 cytokines. And they interact, or they are produced through the interaction of the root system of the embryo, through it releasing a substance called HLA, mainly HLA-C, working with certain cells in the uterus called T regulatory cells and activating the activity also through a mechanism called killer cell immunoglobulin receptors that are present on the surface of the cells of the invading trophoblast. That interaction causes the balance that I spoke about between type 1 and type 2 cytokines. You don't have to measure the T regulatory cells and the KIR, which many labs that do the testing do. It's expensive, doesn't add anything. What we've got to know is that the natural killer cells are not overproducing the type 1 cytokines that kills the roots of the embryo, because if there's overexpression of the type 1 cytokines, you'll end up with the pregnancy's root system being destroyed, and you may lose the pregnancy before you even know you're pregnant, thinking you're infertile, but you're having a very early mini miscarriage. You could have a chemical pregnancy. There are many in your areas, and you should not do the tests there. The tests must be done in one of 3 or 4 labs. The one I work with preferentially, not exclusively, is in Boston. It's called ReproSource Laboratory. We can help facilitate those tests for you, but it's really important that it be tested. The tests we use are obviously looking at the cytokines. It's a blood test, or we can do a test called the K562 test, which is a biological test that can only be done in a sophisticated lab. And we measure it. The results take 12 days to come back. When they come back, you get a copy of the report. Once you have a copy of the report, you reach out to us, and I'd be happy to sit down if you become a patient of ours and discuss with you what that means and what needs to be done. So that's really important to know. But there are other things we measure too that also interact with the natural killer cells, things like antiphospholipid antibodies, thyroid antibodies, and also looking at all the immune lymphocytes in your system, doing what's called an immunophenotype, which they all do at the same time. And we get that in the overall results they send us. Now, you can measure the T regulatory cells, you can measure a KIR, and it is done by many. I don't believe it's necessary. All I have to know is, do you have activated natural killer cells that are overexpressing the type 1 cytokines that kill the roots of the embryo, or do you not? And if you don't have that, if you do have that, are there other adjunct things we've got to treat, such as phospholipid antibodies, where we treat with Lovenox, which is a heparin-like substance, and or do you have activated T cells? And if you do, then we need to treat also with steroids like dexamethasone or prednisone. So that's the basis of the autoimmune variety. Again, most women with autoimmune problems don't miscarry repeatedly. They lose the pregnancy before they knew they were pregnant. The doctor keeps putting in good quality chromosomally normal embryos, but they don't get pregnant. And young women should, under 35, 3 and 4 of the embryos they produce should be normal. So for that reason, if you're young and you keep miscarrying, or if you've had IVF with embryos put in the uterus and you keep miscarrying and you have natural killer cell activation, it is usually not going to be due to an autoimmune cause where you wouldn't even know you're pregnant usually. But when you miscarry repeatedly, by definition, recurrent miscarriage is 2 or more miscarriages in a row, then the cause is very often not the embryo, but the receptivity of the uterus. And those 3 factors I mentioned need to be looked at. Again, the regularity of the cavity, the thickness of the lining, and the immune competence of the uterus. Now, if you've got repeated miscarriages and it's due to the natural killer cells being activated, it's not usually due to what we call autoimmune, which is where your body reacts to its own tissue. It is rather likely to be due to what we call alloimmune. And that means that you and your husband share certain genetic similarities. Now again, very few doctors are familiar with or understand this fully, and when they tell you, we don't believe it, you need to ask the question. Tell me what it is you don't believe, and most will not be able to. You read that thin 50-page book that you can get by simply going to my bio and clicking on the link, and you'll understand it far more than most doctors do. So I urge you to do that. If you've got an alloimmune cause, it's because you and your husband share certain genetic similarities, and if it involves certain genes, involving HLA genes, mainly one called DQ alpha, and if you and your husband share that, then the embryo will contain the paternal DQ alpha, and when it gets to the uterus, it will be viewed by your uterus as being too similar and therefore not being welcome. it'll be a hostile, invading organism from the point of view of the uterus, and the uterus will then try to get rid of it. And how does it do it? It repeatedly increases the amount of natural killer cell type 1 cytokine expression. It activates the natural killer cells. So it's very important to know this. How do we find out if you've got a match? You and your husband's blood gets tested to see whether you share DQ alpha HLA, and that's again done at Reprosource Laboratory in Boston, and we can help you facilitate that. If you share DQ alpha, usually it's only 1 out of 2 genes that everybody carries that is shared. And that means that 1 out of every 2 embryos getting to your uterus will match your DQ alpha makeup if even one of them are similar to you. And so when that happens, your embryo won't be a problem in attaching unless you've already developed natural killer cell activation. And that takes repeated exposures over time to build up. That's why it's so common for us to see women who've actually even had a baby, and then they can't get pregnant or they miscarry over and over. Because when they got pregnant the first time, even if the DQ alpha match was there, they still had not yet built up and developed a high enough level of activated natural killer cells to be a problem. And both must be present for there to be a problem. So we test you for that. And we can't test the embryo to see if there's a match. We're going to test you and your partner to see if you've got a match, and then work out what the odds are that you are a match, and treat it as such by putting back a single embryo at a time, hoping that the 1 in 2 we transfer to your uterus, the one at a time, will not contain the matching DQ alpha. Remember, that happens only 1 out of 2 times in most cases. And if the right embryo that is chromosomally normal by PGTA testing comes into the uterus, and we have dealt with the natural killer cell issue, provided, again listen carefully, provided that you don't have a match in that embryo, the embryo will have a 60% chance of taking. But if there is a match, it won't take. And that's why every time we put 1 embryo in the uterus, there's a 1 in 2 chance of a match. And even if we get rid of the natural killer cell activation by infusing intralipid and steroid administration, which is the treatment, and we bring the natural killer cells into balance, you're still not going to have a pregnancy unless that embryo is a non-matching embryo. If it matches, it's lost. And there's nothing we can do about it. I had a young lady, her name was Carmen, came to me after 14 miscarriages at the age of 34. It was due to this alloimmune cause. I virtually adopted her. She's a wonderful young lady. She treated disabled children, and I took her on as a charity case. And eventually we did an IVF on her, and we got 7 embryos. She now has 3 children, 2 boys and a girl, because we were able to identify that she had this immunologic alloimmune problem, treat her with intralipids, put in 1 chromosomally normal, PGTA normal embryo at a time under this cover, and then she got pregnant 3 times, had a baby. She got pregnant another 2 times, and she miscarried because they were matching. And as I told you, there's no way of knowing it up front. So the answer to your question that you asked earlier on, the young lady I said I'd get to, is you've got to identify, quantify, and typify the variables that can affect the quality of the seed, and that's primarily the chromosomal makeup, which is linked to the woman's age and is linked to whether she's got a reduction in egg quantity, such as diminished ovarian reserve, we call it. And then you've got to use an individualized protocol to protect the eggs that may have a chance in that cycle, so you can come out with that egg not being corrupted by the wrong hormonal environment that occurs in older women and women with diminished ovarian reserve and women with a condition that used to be called PCOS that we'll be dealing with down the line, now called PMOS, and if they've also got an increased risk of the embryo being abnormal. And once we get the normal embryo through the proper stimulation,
do PGTA on the embryo. We know it's normal. We freeze it and bank it. We put back one at a time into the uterus that has been treated with intralipid and steroids, prednisone or dexamethasone. And one at a time, if there is an alloimmune cause, and when the right one comes along, you'll get pregnant again. You've got to look at those variables that can affect implantation. I told you, and I want to re-emphasize, if a woman with normal embryos doesn't get pregnant when they put in the uterus, it's usually an autoimmune cause if there's an immunologic cause. Because 60% of the time, the embryo should attach if there is a normal chromosomal embryo reaching the uterus, which is far less likely to occur as you get older. And that's the one thing. But if you repeatedly miscarry, the likelihood is that if you've got natural killer cell activation, it's not autoimmune, which is an easy one to fix, but rather it's alloimmune. And that's the more difficult one to treat, and that may be where you need us. And for those of you listening today, please get those books and get the article I've just written on this topic, which also comes to you free without any commitment. And you may, if you are in that realm, need to talk to me. And if you do, click on the other little icon, which lets you get access to a questionnaire, which you can fill in 4 minutes. We'll reach us and we'll reach out to you and arrange to talk with you. Hopefully this gives you some background and launches this conversation in the next hour and a half, make it more lively and more meaningful. Again, there's not a single reason why every one of you here should not get the book and not get the articles. Get the books and the articles. They're free without commitment. If you don't want to talk to me about your problem, that's fine. But if you do, it's a first come, first serve. So you need to do it quickly, and you need to click on that link, and we'll get back to you and discuss with you all of the issues relating to it.
Alrighty, perfect. If you guys are just now joining in on the live stream, Dr. Scher is answering RPL, recurrent pregnancy loss questions, and anything to do with that topic. If you have a question about RPL or miscarriages or something along that, please go ahead and comment it and we'll answer it the best way possible. In his link in his bio, he has free resources, articles, books, and so much more there that will only be available for today's live stream. So go click on that link. You get it immediately. There's nothing that you need to give us in return. And if you want to talk to Dr. Scher one-on-one directly, there's a little questionnaire. It takes like 4 minutes to fill out. I highly recommend everyone go do that. So we're going to start answering questions. Go ahead and drop your questions about IVF or specifically RPL in the comments, and I'll get to you in a second. We're going to answer Zane Salman on TikTok here. He said, "Hello, doctor. I am 6 weeks pregnant with my twin babies. I got bleeding today. It is bright red. Any suggestions?"
Well, bleeding can come from behind the root system of the embryo, as I told you. It can be a revealed bleed. Remember I mentioned if it gets collected there and it can't escape, it forms a subchorionic hematoma, which is not good, but it doesn't mean it's the end of the world. Bleeding is extremely common in pregnancy. And so I wouldn't be overly concerned about bleeding unless it gets heavier and heavier and is associated with building cramping. When that happens, you may be on the way to a miscarriage. The bad news is there's not much you can do about it if it becomes inevitable. But you've got to keep an eye on it. And the only way to know where it's headed and what it's doing is to be tested. And that requires ultrasound exams and blood tests of your blood pregnancy hormone to see if it's still rising properly. But ultrasound exams after 6 weeks, done every week, will give you a good idea as to whether the pregnancy is surviving. If there's a heartbeat present and it's over 120, 100 or more is not too bad, but over 120, but less than 180, you've probably got a viable pregnancy and you need to keep an eye on it.
I'm going to answer Kane on TikTok here. This is recurrent implantation with a partial separate. My clinic are dismissing this, question mark.
A partial what?
Septate. Septate. I don't know if
that means you've got a little indentation of the uterus. That is a congenital abnormality. The uterus is formed from 2 separate parts. They're like 2 bananas coming together in the midline, and they fuse. and the banana skin in the middle is retracted, leaving you with a rounded appearing uterus with two tubes coming off the ends of the banana, fallopian tubes. That's the normal. And in some women, that banana peel in the middle doesn't retract properly, and you have a little dip or an indentation. Your doctor is right. It will not cause a problem if it's a minor indentation. If it's a big one that goes all the way down the uterus, you may have to review it. But I would urge people not to remove small little dimples in indentations of the uterus just because you find them. It will not cause miscarriage early on. Now, it may cause problems later in pregnancy because the uterus is nicely rounded inside in the cavity. The baby can roll about and have its head pointing in the right direction. You may end up having to have assisted delivery, such as maybe even a cesarean birth, but it will not cause you to lose the pregnancy. And if you know it's there, you can treat any early contractions, relaxing the uterus, allowing it still to expand. So I would agree with your doctor. Don't simply go in and remove a septum because it's there unless it's very pronounced. If it's going to cause losses, they're not going to occur till much later in pregnancy, and there's a lot you can do to prevent that through medication at that time. The problem with doing the septum operation is that the surgery itself can cause scarring in the uterus. And as I mentioned right in the beginning, if there's scarring in the uterus, it can irritate the lining and make it harder to get pregnant or stay pregnant.
Additional information here. It says, I've been told it's 40% on my uterus, and I've had one missed miscarriage at 6 weeks. That's also additional.
That is not the reason for the missed miscarriage, in my opinion.
Okay, we're going to go to the next question here. We're going to answer Sydney Clark, our number 2 viewer currently on TikTok. They said, I had 8 eggs retrieved and all were stalled at M1. They told me it was egg quality. Is this correct?
Listen carefully now, this is important. The question is, because all your eggs were M1, does it mean it's egg quality? Yes, at that point, it's a quality problem because you want an M2, an egg that has gone through the normal process of reproductive division called meiosis to prepare it for fertilization. If it's an M1 that occurred irregularly, so the egg that you get and have harvested was not normal, and the chances are that that egg is not going to be able to produce a viable pregnancy. There are cases where you can mature it overnight in the lab, but it's not as good as it happening in the ovary. Usually this is due to a number of causes. One, advanced age. When you get beyond the age of 40, the chance of the egg not responding properly to stimulation is greater, and you end up with problems. It's more likely in women that have diminished ovarian reserve. An AMH of under 1.5 is reason to be concerned that you're running out of eggs. So that's the second one. And those two things, there's nothing you can do to change. All you can do is protect those eggs, and there'll always be some that are okay, by using the right protocol for stimulation that is responsible for their development to get them ready. The protocol used for ovarian stimulation in a large number of these cases is the reason you got bad eggs. So you ended up with abnormal eggs, not because they started off without the potential to be normal, but because they were not allowed to develop properly through using a one-size-fits-all recipe approach for stimulation. You need an individualized approach for ovarian stimulation. I did a webinar on this recently, and you can find that on YouTube if you go there and look it up. But other than that, I'm more than happy to talk to you because I think you may very well be someone I can give advice to. I can tell you by going over your history whether the protocol you used was conducive towards that embryo, those eggs being normal, because it's the egg and not the sperm that is primarily responsible for making good embryos. It's primarily the egg, not exclusively, but primarily. And that requires a protocol that doesn't create the wrong hormonal environment in the ovary that can prejudice development of the egg, because an egg that doesn't develop properly won't come out being either normal, it could even be mature, but still abnormal. So it's really important that that be looked at very closely. Please take the opportunity to read the articles, go back and view my YouTube presentation on this, and read the articles and the books that are available to you. And if you want to talk to me, click on the link that gets you access to the questionnaire.
That's perfect. All right, if you are scrolling and learning and just got into the live stream right now, we are answering questions on RPL, recurrent pregnancy loss, or miscarriages. Anything to do with that topic, go ahead and comment it. We will get to you as soon as possible. We're doing our best to answer as many as we can today. If we don't get to your question today, or just if you get some free time, go check out the link in our bio. There are tons of free resources there. There are articles that are exclusive for today only for you guys that Dr. Scher wrote this weekend for you guys. Go get those. They're going to be gone after the next 24 hours here, so it's exclusive. If you're filling it out right now, I'm seeing emails come through. Thank you so much. We appreciate it. I'm going to answer here Flower Garden on TikTok. She says, I'm 43 years old. I did IUI. I had 2 miscarriages back to back. Any suggestions?
Well, I mean this with great respect and deference. IUI should never be done in women over 40 because the baby rate is 1 in 40 or 1 in 50. You should not be doing it because remember, with IUI, if you're a normally ovulating woman and you get stimulated fertility drugs, you may make a lot of follicles. Believe it or not, contrary to what most people understand, you will only release 1 and rarely 2 if there's a family history of twins. So you'll release 1 egg. But at 42, only 1 out of every 10 of your eggs are going to be normal. That means there's a 9 out of 10 chance that the egg that reaches the ovary to be fertilized will be chromosomally irregular, incompetent, referred to as aneuploid. And those are the embryos that miscarry easily. Those are also the embryos that usually don't attach. So women who are over 40 should not be doing IUI, in my opinion, and I say that with some reluctance, because I'm the person that introduced IUI into the field of medicine in 1984, and I've written widely on the subject. There are contraindications to IUI. One of them is people that are older than 40. 2 are women that have got diminished ovarian reserves, AMH of under 1.5. 3 are women who've got immunologic problems. And 4 are women that have repeatedly been trying for protracted periods of time. And another one that I think is a contraindication, not relative, is when there is endometriosis, regardless of severity, because the chance of getting pregnant with endometriosis is 5 or 6 times lower per month of trying because of the toxic, harmful environment endometriosis establishes in the pelvis that damages the egg as it tries to get to the tube to be fertilized. So, bottom line, endometriosis shouldn't be doing IUI no matter how old you are. And I also don't think it's a good idea for women with polycystic ovarian syndrome because those women do release a lot of eggs at a time. And whenever you go reading a National Enquirer or the Globe that you pick up at the supermarket and you see a woman coming out of the hospital carrying babies in both arms and you say to yourself, oh, isn't that cute? She's got so many babies at one shot. It's not cute because those babies are in jeopardy. They were probably born prematurely. You don't want to carry more than 1 baby at a time if you can avoid it. More than 2 is not a good thing. You lose 1 out of every, if there are 3 babies or more, at least 1 will be lost or be severely damaged by being born too prematurely as a consequence of carrying too many babies. So you don't want too many. And women with PCOS, now called PMOS, these are the women that are more likely to carry multiples. So when you do IUI, you can't predict how many eggs are going to reach the tube where the sperm is. And so you can end up with multiples. Only way you can avoid that is by putting back 1 embryo at a time. So PCOS women who do IVF get access to all their eggs. We can test their eggs, and we should, because PCOS women are more likely to make abnormal eggs. And these eggs, these embryos can be tested through PGTA and put back over time, 1 at a time, or 2 at a time at most, and avoid higher order multiples, which are triplets or greater and dangerous.
All right, we're going to answer pretty key on TikTok. They said, I had 3 miscarriages. My blood, thick blood. Been trying to, sorry, let me open up the message again, to get pregnant since 2020. Any suggestions?
I didn't hear the first part.
I had 3 miscarriages. My blood is thick. Been trying to get pregnant since 2020.
I don't know what you mean your blood is thick. It's foreign to me. Having had 3 miscarriages, which occurs in only 1% of pregnancies, again, it is obviously recurrent pregnancy loss because it's 2 or more. The incidence of recurrent pregnancy loss with 2 or more is quite high, of it recurring over and over. And if you've had it 3 times in a row, it's very likely to keep recurring, and it could be due to the factors I mentioned. It could be due primarily to the implantation problem, because most women who have recurrent pregnancy loss need to be looking at implantation rather than the embryo's quality. And that needs to be evaluated in the way I described, and which is present in that article that you can get free of charge by clicking on the link. There's no requirements, nothing, it doesn't cost you anything, and you're not under any pressure. Get the article, get the book on recurrent pregnancy loss, which I also provide free there, and read them. It's going to help you.